Welcome to Nova Signal Academy, where we provide training, education, and resources to physicians and sonographers. My name is Toni Mullins, and today we're going to discuss transcranial Doppler and sickle cell disease. Our objectives for today are to provide you a basic background of TCD and sickle cell disease and how to assess for vasculopathy in sickle cell disease by using transcranial Doppler.
What is sickle cell disease? Sickle cell disease is an inherited red blood cell disorder in which the red blood cell becomes misshapen, as you see in the diagram in the center. There is a healthy red blood cell and a sickled red blood cell. This sickled red blood cell is the major cause of stroke in our pediatric sickle cell population. The sickled red blood cells, they're fragile and they break down easily, and this in turn will release a protein that increases inflammation. It also increases clotting, endothelial damage, and it can cause vasoconstriction. Now, the risk of stroke is highest during the first decade of life for our pediatric sickle cell patients, and they're at risk of stroke 333 times greater than that of a healthy child without sickle cell disease or heart disease. In children with abnormal TCD studies, the risk is 3,000 times greater for stroke. And approximately 11% of sickle cell disease patients have clinically apparent strokes before the age of 20. The introduction of TCD in sickle cell disease began with pioneer Dr. Robert Adams. It was an evolution of a 20-year effort to develop a strategy to prevent stroke in pediatric sickle cell disease. It began with a chance meeting in Germany in 1986 to a press conference in Washington, D.C. at the National Institute of Health in 1997. 1982 was the introduction of TCD by Rune Aslid for subarachnoid hemorrhage. At this time, the big question became, would TCD work for sickle cell disease? So the evolution of the STOP protocol began. Now the STOP protocol is stroke prevention in sickle cell anemia. This is one of the most effective stroke prevention strategies in medicine. The Medical College of Georgia cohort, the New England Journal of Medicine, was in 1992. From there, STOP, 1998, STOP 2, 2005, SWITCH in 2012, and TWITCH in 2016. Once it was clear the risk of stroke in sickle cell disease was related to transcranial Doppler, then this indicated that acting on Doppler will prevent strokes. Now, the STOP 1 trial was the first randomized controlled trial of regular transfusions in sickle cell disease for any indication. It was the first randomized controlled trial based on transcranial Doppler. And it was the first randomized controlled trial for stroke prevention in children for any indication. Here is a review of the stroke prevention trial in sickle cell anemia, the STOP trial design, and the STOP trial results. The STOP 1 trial in 1994 was a multi-center clinical trial. This demonstrated such a significant benefit of chronic red cell transfusion in reducing stroke by 90% that the study was halted. It was halted before its scheduled closure on the advice of the study's data and monitoring board. Based on these findings, the National Heart, Lung, and Blood Institute issued a clinical alert. They recommended the TCD screening of children with sickle cell disease, and they also recommended chronic transfusion to prevent stroke for those who are at high risk. Here is the publication in 1998 showing prevention of a first stroke by transfusion in children with sickle cell anemia was related to results on transcranial Doppler. It was proven that high mean velocities on transcranial Doppler were identifying patients, sickle cell patients, that were at high risk for stroke. The next trial was the STOP-2 trial. Now, the STOP-2 trial was the highest quality data based on the STOP study. Here is a review of the design and the comparison to the STOP-1 trial. The STOP-2 trial was also halted prematurely. The National Institute of Health recommended that transfusions be continued indefinitely for children at high risk for stroke and sickle cell disease. Next, we're going to talk about the Twitch study. First, you may ask, why would you stop transfusions when transfusions were preventing strokes? They were solving the issue at hand. However, there were other issues with chronic transfusions, such as iron overload. So, TCD with transfusions changing to hydroxyurea, the Twitch study, this was for high-risk children with sickle cell anemia and abnormal TCD velocities, that after 4 years of transfusions and without severe MRA vasculopathy, it showed that hydroxyurea therapy can substitute for chronic transfusions to maintain TCD velocities and to prevent primary stroke. Now, the impact that transfusions made at preventing stroke was clear. Reduction in stroke in children with sickle cell disease has been documented. TCD and STOP have changed the landscape of stroke in sickle cell disease. It dramatically reduced the first stroke in children. It reduced hospitalizations for strokes in sickle cell disease pediatric patients. Now, despite the compelling reduction in stroke risk, the acceptance of the STOP strategy was limited by concerns of iron overload with chronic transfusions. Thus, hydroxyurea and the Twitch study. A gradual decrease in transfusions and an increase in hydroxyurea was proven beneficial. Next, Dr. Robert Adams published Big Strokes in Small Persons. This categorized a TCD risk stratification. We have criteria that can distinguish between normal, conditional, and abnormal for TCD mean velocities. This meant that below the mean velocity of 170 centimeters per second was a normal mean velocity to find in sickle cell pediatric patients. The risk became higher for stroke once this mean velocity exceeded 170 centimeters per second. And it was clear at 200 and above that the risk for stroke became more significant. Where are we today with TCD and sickle cell disease? The FDA considers TCD a surrogate endpoint for stroke. TCDs are performed on sickle cell patients from the age of 2 to 16 years. Sickle cell disease pediatric patients have one TCD performed annually, unless the mean velocities are elevated above 170 centimeters per second. The TCD is repeated within 2 weeks to confirm the mean velocities before treatment options begin. The most common treatment methods include hydroxyurea or chronic blood transfusions. There are new trials and research that continue for sickle cell disease that are very promising. Pediatric sickle cell disease location of vasculopathy is typically in the intracranial carotid system distal to the ophthalmic artery and extends into the middle cerebral artery. This is where the mean velocities will tend to be elevated. The vertebral basilar system is typically spared of disease. The TCD protocol for sickle cell disease pediatric patients focuses primarily on the MCAs and terminal ICAs bilaterally, The ACAs, PCAs, and basilar artery are all included in the protocol. However, the MCAs are typically followed every 2 millimeters throughout the length of the vessel to isolate any abnormalities. Pediatric patients will have different depths of incination for vessel location compared to adults. Adults' MCA-ACA bifurcation can be found routinely at 62 millimeters. However, in young pediatric patients, it is not uncommon to find the MCA-ACA bifurcation at the depth of 50 or 52 millimeters. The temporal windows used in TCD are commonly slightly more anterior than an adult patient. An adult patient, a temporal window at 1 is very common. For pediatric patients, a temporal window at 1 and at 3 are both very common. There is a different limitation that is found in the sickle cell disease population. Due to the vitamin D deficiency that is common in this patient population, it can lead to loss of bone density. So, in turn, this loss of bone density can cause insufficient temporal windows in this patient population. Here is a basic step-by-step guide for scanning pediatric sickle cell disease patients. You will use a 2 megahertz probe and place it at the right temporal window. Window 1 or 3 are your most common windows to use for the pediatric population. Ensure parameters are adjusted accordingly on the TCD equipment in regards to power and filter, etc. You begin at a depth typically around 50 millimeters. You will rotate the probe in slight rotations to find the most optimal signal. After a signal is found, the temporal window has been identified. Next, you will optimize the signal by aligning the ultrasound beam to the artery by using minimal angle adjustments. Never settle on your first signal. Always search for your highest mean velocity. This is very important. You angle the probe anteriorly from window 1 and center from window 3. This will isolate your middle cerebral artery. Decrease depth to the most superficial segment that is visualized in M mode once you have an excellent signal. Walk the depth every 2 millimeters until the MCA-ACA bifurcation is identified, showing the red and blue flow in the M mode and the flow above and below the spectrogram. Angle inferiorly from the MCA-ACA bifurcation to obtain the terminal ICA. Other vessels and number of images obtained will depend on the protocols in place at each institution. Best practice includes validation of the criteria used with other modalities. An example, comparing your TCDs with angiograms, CTAs, MRAs, and clinical findings to ensure your diagnostic criteria is accurate. In conclusion, TCD is a proven method used to identify stroke risk in pediatric sickle cell disease. There are unique techniques and limitations to note when scanning this patient population. Please never settle for that first waveform that is identified. Keep searching to find those highest mean velocities. This is crucial for best patient care. Thank you so much for listening today.